Thursday, the 14th of October 2021. As you can see, I'm in the Town Hall in Enniskillen chairing this afternoon. I'm joined by our Chief Executive of Council, Alison McCullough, and by Damien on WebEx. You're all very welcome, and we'll crack on with the agenda. Number one is apologies, if any. I'm not seeing any indications of any apologies. Okay, thank you. And number two is to sign the meeting, or sorry, sign the minutes of the previous meeting held on the 2nd of July 2021. And that's already been done. Number three, declarations of interest, if any. No declarations of interest. Okay, what I'm going to do now is I'm going to move matters arising to the end of our meeting, and I'm going to take item 5, and that's to receive a response from the Health and Social Care Board to the following matters raised by members, and that's 5.1, rules regarding registration with local primary care GP practices and the related issue of GP access. And we're joined by Orla Donarchy, Interim Assistant Director of Business Service Organisation, Maria Coyle, Business Coordination Manager, and Dr. Kevin Cosgrove, GP Medical Advisor of the Directorate of Integrated Care, Health and Social Care Board. So I'll just bring the Chief Executive on at the stage. Chief Executive.
No, Chair, it's just one update really in terms of attendees. It's just to advise we have an apology from Louise McMahon, and Louise is being represented today by Mr. Michael Donaldson, who's the Assistant Director of Integrated Care in the board, and also to advise that Dr. Cosgrove is now unable to attend, so Dr. Ciara McLaughlin, who's one of the medical advisors in the board, is attending in his place. So just with those amendments, Chair, as the attendees as you've outlined.
Okay, without further ado then, we'll carry on. Orla?
Hi, good afternoon, Chair and Chief Executive and other members. Yes, I have been asked to give you a presentation today on the rules regarding registration with local GP practices and related issues for GP access. So I'm very happy to be here and take this opportunity to share this with you. Can I have the next slide, please? Okay, so just for yourselves to understand the relationship between BSO and the Health and Social Care Board, the BSO provides the business functions on behalf of the Health and Social Care Board in respect of their primary care contractors. So those functions include the registration of contractors, e.g. doctors, dentists, pharmacists and opticians as well. The payment of those contractors and the delivery of the services to the public. The registration of patients with a GP and the verification of patient entitlement to access publicly funded healthcare in Northern Ireland. And all those services are provided by BSO on behalf of the Health and Social Care Board through a service level agreement, which is renewed annually. And should any new requirements come on board, we negotiate with the board and agree what those services should be. Could I have the next slide, please? So just before we start off and we get into some, I suppose, detail around the process of entitlement and registration, etc., I think it is useful to maybe just set out some common misconceptions relating to patient entitlement in Northern Ireland. So there's a number of just, I suppose, thoughts on that in regards to what people notionally believe they're entitled to. So first of all, that anyone can register with a GP. And this isn't just actually the case. They have to demonstrate their entitlement to be registered. And that also includes cross-border workers who potentially could be delivering services on behalf of health and social care as well. Second one there is if you have a health and care number, you're entitled only if you are a resident of Northern Ireland, and that's the way our legislation is modelled as such. If you are issued with a medical card, you are entitled. And that is only the case if your entitlement has been verified by BSO and you currently reside in Northern Ireland. If you were born in Northern Ireland, you're entitled to healthcare, only if you currently reside in Northern Ireland. Could I have the next slide, please? Further misconceptions, if you're married to a person from Northern Ireland, you're entitled, only if you're lawfully residing in Northern Ireland. If you hold a British passport, you're entitled. Once again, if you're residing in Northern Ireland, you would be entitled. If you're entitled to get healthcare anywhere in the UK free of charge, that's only if it's an immediately necessary treatment in Northern Ireland. You need to go to A&E or you need support from a doctor, and a doctor would decide whether you need that care or not. Once registered with a GP, you will always be entitled, and that's only if you are currently residing in Northern Ireland. So a lot of it depends on you actively residing in Northern Ireland. Can I move on? Thank you. Healthcare in the UK is a devolved matter. So the 4 regions all have different legislation that oversees the entitlement of healthcare. The rules of entitlement vary as well between acute hospitals and GP access. So primary and secondary care is different in regards to the rules that govern it. So my phone's just gone off. Apologies for that, my phone just went off. Sorry, could we move on to the next slide? Okay, main legislation which rules and the access for healthcare in Northern Ireland. Health and Personal Social Services Order of Northern Ireland 1972 is the key piece of legislation which oversees the entitlement to healthcare. And it states it shall be the duty of the Ministry to provide or secure the provision of integrated health services in Northern Ireland designed to promote the physical and mental health of the people of Northern Ireland. So it's very important that it is about Northern Ireland, and we are driven by that legislation and being resident in Northern Ireland. The Shah and Barnett London Borough Council 1983 case law sets out the test for an ordinary resident of Northern Ireland, which is applied to determine if a patient is entitled. And the main elements of that test are whether someone is lawfully in the UK, they're residing in Northern Ireland, and also that they have a settled purpose, i.e. have a reason for being here, whether it be studying, whether it be living here, etc., etc. Can we move on to the next slide? Other pieces of legislation which also have a factor in regards to individuals' access or entitlement to care relate to the provision of health services to persons not ordinary resident regulations of 2015. And that's where a patient is not ordinary resident, i.e. they may be a visitor, and those visitor requirements are identified in that piece of legislation, and they must satisfy exemptions under these rules. Additionally, reciprocal arrangements with the UK, and a patient may benefit under an arrangement between their country of residence, their citizenship, during their visit to Northern Ireland, and treatment will be provided in accordance with the terms of this agreement. To date, we believe in regards to Northern Ireland and the UK since the withdrawal agreement and the EU exit process, that there are roughly 8 reciprocal agreements, which means countries have already entered into agreements with the UK to allow their nationals, if they're visiting Northern Ireland or the UK broadly, that they can avail of healthcare. Can we move on, please? Other legislation affecting the entitlement is the UK Immigration Act of 2020, the EU Withdrawal Act of 2020, and the Trade and Cooperation Agreement of 2020, and all those relate, as you can imagine, to EU exit. Can we move on, please? So in actually determining whether someone is entitled to treatment and it's an emergency situation, it is really the opinion of a medical practitioner as to whether it'll be provided free of charge as secondary care. And unless it is determined that the person travelled into NI to obtain treatment. So that would be the case of, say, someone has travelled in for healthcare tourism. So that's why we rely on our doctors to determine whether someone should avail of that treatment at secondary care. Can we move on to the next slide? I think it's useful at this point then just to explain the process that would be overall how someone becomes registered and how we determine entitlement. So I'll just take you through the stages of that, if that's okay. So a patient completes a registration form and provides proof of their lawfulness. So their lawfulness could include a UK or Irish passport, their proof of EU settled status in the UK, and that could be a card or a share code issued by the Home Office. It could be as well a UK biometric residency permit or card or a shared code issued by the Home Office as well. On the basis of that information being received, BSO determines the patient is lawful in the UK and the patient is registered with the GP practice. The patient will have to provide additional documentation to the GP practice in accordance with the practice requirements. So that could be their address or incomplete in other forms, which we in BSO don't have an interest in, but it is fundamentally to demonstrate for the GP, say, that they're within the 10-mile radius or catchment of the GP practice. Can we move on to the next slide? So what happens after registration? Details for each adult patient are matched using software to check for an economic footprint to demonstrate residency in Northern Ireland. And we run that based on the information that has been provided by the patient at the time of the registration. So the patient details which are checked are their surname, their forename, their date of birth, their address and their postcode. The check happens approximately 12 weeks after registration. The BSO do not receive any other information about the patient in that time. We move on. If the patient details are not verified through that economic check, then the BSO will write to the patient requesting them to provide satisfactory documents to support their claim to residency. These may be payslips, benefit award letters, a letter from a school or university. It depends on the circumstances of the individual as to what information we would seek from them. If they do not respond or provide satisfactory documentation, they will be removed from the GP list. Can we move on? The patient registration journey for visitors, on the other hand, so someone who is just here on a short term in Northern Ireland and not seeking to demonstrate residency, the patient will be required to state their reason for being in Northern Ireland and which exemption they wish to benefit under. They are required to provide satisfactory proof of their entitlement. For example, say we may have missionaries coming to Northern Ireland, and this is the regulation we've just picked out as an example for yourselves. If someone was a missionary, they would be required to provide proof of lawfulness in the UK, passport or UK visa issued by the Home Office, proof of employment or status as a missionary overseas, e.g. a payslip or a letter confirming their status, and details of the organisation or establishment in the UK, whether it's a registered charity or company registration. The BSO will determine if the patient can benefit under the exemption claim before they can be registered. Can we move on? The following information is available then on our website, so should any of the members of today's meeting wish to follow up on our website or indeed advise any of your constituents, our website sets out details of the registration forms in different languages, because we recognise we've quite a number of foreign nationals who are here in Northern Ireland and who may wish to register in their language, which is more meaningful to them. Information on the different types of documents which they can provide to evidence lawfulness, and as well as that, the legislation which oversees the entitlement and the details around registration, which, as I mentioned earlier, is the Health and Personal Social Services provision of health and services to persons not ordinary resident regulations in Northern Ireland 2015 as amended. Lastly, we have information on the documents required for different exemptions under the above regulations, so individuals can maybe understand, given their circumstances, what evidence they would need to provide for those exemptions. And we also have a fair processing notice set out there in regards to how we use their information in respect of GDPR, etc. We'll move on. And that's it. That's the end of the presentation, and we'll happily take any questions.
Okay, thank you very much, Orla, for your presentation, and
Sorry about that.
Plenty of food for thought, so to speak there. Okay, open to members now for questions. And first up is Councillor Barry McAduff.
Thank you,
Barry.
Chair. Thanks very much, Chair. Just on a point, Anne-Marie Fitzgerald, Councillor, has been struggling to get into the meeting. If she could perhaps get IT help. I think maybe she's in already, but I know she was having difficulty there.
No, she's not in yet. Councillor McAduff, Damon's going to start that matter out. Thank you.
Thanks very much. But my focus in the area of registration would be local in this sense. The best way to do it is to give an example. If somebody lived in Omagh and was registered in Omagh, but then they move till Pomeroy or Berra, and they're kind of not allowed to remain in their previous GP practice, and now they're trying to get a local practice to the village or area where they live, but the local GP practice is oversubscribed. So they're in a catch-22 situation where the former GP practice, doesn't hold on to them any longer, and they can't gain admission to a new GP practice. That's a problem that I have met on a number of occasions with respect to constituents. So I wonder, is it appropriate to ask Orla to address that issue?
Thank you, Councillor McAduff. Orla.
Barry, I'm going to defer to my Health and Social Care Board colleagues, because we in BSO, as I mentioned earlier, oversee entitlement. We don't actually determine the rules around access to the GPs in respect of proximity and the catchment area. So I'll defer to Michael if he would care to answer that question.
I think Ciara maybe is best placed to answer that one.
Fair enough. Sorry, Ciara.
No problem. Thanks for your question, Councillor McAduff. Yes, I suppose if I just want to give background to my GP medical advisor for the board, but I'm also a practicing GP with a partnership in Derry, so I do half time in both jobs. In terms of when patients move outside the practice registration area, whenever they register their new addresses, this would automatically account for a deduction from their old practices list. And you're quite right that they would have to seek registration elsewhere. If they are now living in a place where perhaps there are some closed lists and it's difficult for them to find a practice to register with, they are free to contact the board or BSO to inquire as to which GP practice lists are open. And should it be the case that there are none within their catchment area that are open, it is within the discretion of the board and the BSO to allocate that patient to a practice, even if they have a closed list. But generally, there are no caps on GP numbers, but sometimes perhaps because of circumstances such as GP illness or retirements and things like that, sometimes GP practices struggle and they may have agreed a short list closure with the board, but that doesn't stop people from being allocated to them in exceptional circumstances such as these. So if there are any problems for your constituents in relation to that please contact the Health and Social Care Board, the local offices, and we can endeavour to help them in this respect.
Thanks very much, Ciara. That's very helpful.
Okay.
Thank you, Ciara. Thank you, Councillor McAduff. Are you okay then? Yeah. Okay, next up is Councillor John Coyle. John.
Thank you, Chair, and thank you for the presentation. And I commend all GPs and nurses that worked through the pandemic and everything else, but constituents are raising with us about getting face-to-face appointments. I think it is starting to move now that GP practices are seeing face-to-face, and that's very much welcomed because for the last 18-19 months of having no access, medical conditions, having phone calls was fantastic, but may not treat every ailment. So it's just about, is there a plan for in the future, for to keep the services opening and face-to-face appointments available for our constituents. And number two, you may tell me, no, I'm talking to the wrong people, but that's fine. But please, I have in my own Aaron North constituency, there is a GP practice that make patients pay for their medical records and for letters for PA, for benefit claims. Is that contractually in GP's practice that is free of charge, or does that step outside? Or because there is people and they do be saying to me that it's not acceptable. There is vulnerable people in our society that may not have the money to pay for it, but could you advise or say how do we get around it? Thank you.
I think I
Go ahead, Ciara.
to answer this here, I suppose in respect of your second question, which is probably the easier one to answer at this moment in time, patients are entitled under GDPR to a copy of their entire medical notes, so they are from practices without any payment. This here is it is quite a resource drain on practices, but we do it because it's the law. Now, certainly, if a patient perhaps has had their entire medical notes given to them, a copy of them perhaps like 6 months ago, and then they seek it all again, they wouldn't be entitled to a second copy for free. They may have to pay for that then, but they would be entitled to anything that has occurred in the interval between them being given their first copy and their subsequent ask. Okay, so that would be that there. If in terms of payment for non-contractual letters, practices get asked all the time for letter support for maybe somebody's dissertation has been late and various things. So those types of letters would not be NHS or HSE work, and practices would be within their entitlement to request a small fee for that there. In terms of filling out ESA forms and PIP forms, patients should not be paying for that there. The ESA forms within our contract that we complete them for free. This is the forms, mind you, not general letters of support. And the PIP forms attract a small fee, but it's not paid by the patient. It is paid by, well, it's not Capita, but certainly somebody on behalf of the state. If some patients do want more detailed information and more personalised, non-generic format, and it would be classed as a private letter. So yes, they might be asked for that, but they shouldn't be asked to pay for a GP to fill out their ESA form or their PIP form. And certainly, if that was the case, we would want to intervene and make sure that that wasn't happening. So happy to take any feedback on that. In terms of the GP practice and seeing patients face to face, well, I suppose I can speak from my own experience as well as my experience in the board. We have not stopped seeing patients face to face, but certainly the numbers have increased over the past 18 months. Patients were very patient and very understanding at the beginning of the pandemic, and a lot of people were staying indoors, and there was a sharp fall in infectious illness, which is a significant proportion of our acute work that comes in on the day. And some patients did put off maybe talking to us about some things that they might have talked to us sooner about at the beginning of the pandemic, and we're seeing those patients in greater numbers now. The requirement from an infection control point of view does mean that we have to triage all requests for consultations, and sometimes that might be done in a telephone or video consultation, and sometimes we find that actually quite a number of our of patients' needs are being met in that way. It sometimes can reduce the number of patient journeys in and out to the health centre by trying to optimise the resources we have at the time. So back perhaps 2 or 3 years ago, when maybe to sort out one problem, it required maybe up to 3 or 4 visits. Now we can probably sort it out with maybe a telephone or video consultation, a visit to our practice nurse to get the bloods done, and a face-to-face with the GP, and a telephone consultation afterwards. You know, so we are endeavouring to work extremely hard to make sure that we safely manage patients' health needs as best we can, and using the resources that we have wisely. I suppose the big thing is that the number of contacts with the practice, you know, has gone up and significantly, and the number of people to deal with it has reduced to a degree on a day-to-day basis because of competing demands. And the competing demands can be things like, you know, us having to isolate if we have COVID, or if our, you know, household contact, like my child, if my child had COVID, whereas because I'm doubly vaccinated, and if I had a negative PCR test, I could still, you know, go and do my work if I wasn't a healthcare professional. I can't do that there, you know, by being a healthcare professional. So you're sort of stuck that way. But we've tried to compensate for that by increasing the use of remote access for GPs to dial in from their homes and do their work remotely. But it's not as nice as it was beforehand. And certainly I enjoyed my job a hell of a lot more when I was seeing more patients face to face, and it was easier to deal with patients face to face. But we're conscious of the fact that we do have an awful lot of vulnerable patients, people who are, you know, immunosuppressed because of maybe the drugs are taken for the rheumatoid arthritis, or recently been on chemotherapy, or have, you know, had transplants and things like that there. And we're conscious of the fact that, you know, our waiting rooms, which used to be heaving people, you know, cheek to jowl, elbow to elbow, is not acceptable in this day and age. Trying to sort of stagger patients coming in so that there isn't the overcrowding, and deal with patients remotely. We'll take all the same amount of risk. So we will, whether we see them face to face or remotely. It is a much more difficult clinical proposition to see them remotely, but to try and give patients the access that they need. And bear in mind, patients seeking healthcare from us is only a small proportion, not a small proportion, a significant proportion of our work, but it's not the entirety of our work. So there's an awful lot of work going into, you know, following up clinical correspondence, filling out the forms, dealing with patients' repeat medications, doing medication reviews. And at the moment, a huge amount of work is going into the flu campaign and the COVID booster campaign, and we've just come out of obviously having had to deliver that there recently. And so yeah, it's quite a challenge, but please, keep in mind that every practice is probably doing their best, and as a board, we are endeavouring to support practices to do their best and monitor the work that they do, and to draw up, you know, initiatives and to try and support practices, particularly coming into the difficult winter period, and support patients, obviously, in that way.
Well, thank you, Ciara. Are you okay there, Councillor Coyle? Councillor Duff, can you take your hand down, please? Thank you. I suppose, Ciara, there, that you've hit on that point there. I suppose as elected reps, no matter at what level we are, there's a lot of complaints come in about access to the GPs, and it's a real bone of contention out there. I'm hearing of people going to A&E, so they're blocking up A&Es because they can't see their GP. So it is a big issue out there, and I'll let others speak for bringing in Councillor Victor Warrington now. Victor.
Thank you, and thank you for the presentation today. Just before I start, if you could put me down as a declaration of interest, I'm actually on the local Western LCG commissioning group, so if you can put that down, please, for me. I suppose, Ciara, if you don't mind me calling you Ciara, you mentioned where triage, where people are ringing through and they're getting the receptionist, and they're basically, the receptionist asking for the patient to give their symptoms and what their problem is and everything. I suppose the fact that we live in I know certainly, and Councillor Coyle would be something similar to myself. We live in quite rural areas here in Fermanagh, and we live with an aging population, and we also live with a population who don't feel comfortable with giving a receptionist all their details of what's wrong with them. In a lot of cases, the patient will know the receptionist in the practice, and even though we all know that all the employees in the practice can go and look at their notes if they want to, but they're just not comfortable with telling the receptionist their problems, and they don't feel comfortable with it. And I know that I know triage works quite well most of the time, but I think that's one area of it that probably doesn't, when somebody rings in, as I say, that they're not comfortable with giving their information out. Thank you.
Thank you.
You want me to respond to that there?
Yep, please do, Ciara.
Thanks, Councillor Warrington, for raising that there point, and I completely understand where you're coming from, because that's the reason why I'm registered in a practice which is not close to my own practice, because I want to maintain a degree of privacy as a patient myself. But please be assured that your receptionists have a duty, the receptionists in each practice have a duty to maintain patient confidentiality as much as doctors and nurses. It is, written into their contract, and is something that is enforced quite rigorously. I do understand why patients, though, still, even if they're given those assurances, might find it a little bit concerning or difficult to go through all the details of their symptoms. But it really is to try and make sure that they best get their needs met and directed. Now, the receptionists don't do the triage. They just take down the details, and allows the doctors or nurses to triage. So, I mean, in terms of things that people tend to have most difficulty perhaps in sharing, sometimes can be about mental health, or sometimes can be about, maybe, things such as maybe gynae issues or breast issues or things like that there. And, receptionists are very sensitive to that there. They don't have to give the nth degree of detail, but enough in order to convey the urgency of it until they're best meet best categorize that for the doctor to try and make a decision on that quickly. We do have in practice now, I appreciate it's not maybe in all areas, but it is being rolled out, the multidisciplinary team. So practices will be having mental health workers, physiotherapists, with their practice-based pharmacists, their practice nurses, and their doctors. And we're all clinicians, and we're all there to help deal with the huge demands that are in primary care. And if, for example, somebody is suffering from a bit of depression or anxiety, it is really good that if there is a mental health worker there, that they may be able to help that patient, and perhaps allow the GP to deal with the patient who's ring up maybe complaining of a cough and coughing up blood and things like that there. So as to try and have maybe more ready access for very time sensitive conditions, and still deal with appropriately the patient's needs for the practice.
Thank you for that response.
Okay, thank you, Councillor Warrington, and thank you to Ciara. Next up, we have Councillor Diana Armstrong. Diana.
Thank you, Chair, and thank you, Ciara. I just have a couple of questions about services provided by the GPs. But firstly, I've had a recent experience with a very small baby, and certainly access was given and very good treatment given, which did result in hospital attendance. So, I mean, certainly in my local practice in Irvinstown, would be very pleased that that's available for anxious young parents. Really, I'm just asking about female health services, cervical screening and mammograms, the breast screening services. What is the status with those at the moment, please? And I'm just wondering also, do the practices consider any merit in writing to their patients, informing them of updates in the services that are actually happening now, coming out of the situation we've been in, emerging services, and those that are still remaining unavailable, and just as a means of communicating with their patients, because as all elected representatives, we're getting a lot of approaches saying we can't get access to GPs, and that seems a common kind of theme, but it's not in all cases. So it's really to try and dispel that and share the communication. So I'd just like your thoughts on those, please, Ciara. Thank you.
Thanks, Councillor Armstrong, for that question. I'm glad to hear that you found up whenever that experience with the small baby, that you had good, timely access to your GP and appropriate referral onto hospital for that condition. You know, that's the type of thing that we, you know, in the board, and obviously personally as a GP, we aim to make sure it happens as a priority. Practices may have concentrated initially on, you know, how do we manage COVID 18 months ago, and turned a lot of attention there. But we still had patients ringing up with breast lumps in March last year, you know, ringing up if they had, you know, maybe intermenstrual bleeding or things like that there, and those things should be dealt with. You know, people who have got you know, obviously urgent need should still have been dealt with all along throughout the pandemic. Certainly in terms of cervical screening, we restarted our cervical screening after only a very temporary pause, just until we got enough PPE, and we caught up very quickly with anybody who was due to get their smears in the practice, you know, within maybe a month or two. So anybody who is due their smear should be getting called by their practices, and if they're not, then certainly, you know, something they should contact their practice about and inquire. Sometimes maybe if there is, for example, like, you know, maybe practice nurses who maybe usually carry out the cervical screening are perhaps having to isolate, there might be some, you know, unscheduled delays, but they should be rescheduled fairly quickly and caught up. Breast screening isn't something that GP practices are involved with. It is something that is done through, it's commissioned, I think, by the Public Health Agency and delivered by the trusts. But as far as I'm aware anyway, there is still breast screening taking place, because I know I've read results of it this year. I think it might be a good idea, you're right, if practices have maybe stood down or maybe changed the way they deliver some of their services, such as perhaps, you know, we have these multi-morbidity clinics or diabetes clinics or COPD reviews and things like that there, that they would maybe communicate with that to their patients, perhaps via a newsletter or, you know, update perhaps on their website. But you know, we still expect that GPs are delivering as much of their usual contract work as they can, albeit perhaps in slightly different ways to what they did pre-pandemic. Hope that answers your question, Councillor Armstrong.
Yes, thanks very much, Ciara.
You're welcome.
Thank you, Councillor Armstrong. Thank you to Ciara. I'm not seeing any other indications at this minute in time. Is anyone else anything to say, or a query or a question or a comment with regard to GP services? Okay. You happy enough, Alison? Yeah. Okay, we're on to item 5.2, and that's the oral dental health strategy in the context of coming out of a pandemic. And we're going to be joined by Mr. Michael Dawson, Head of Dental Services, Director of Integrated Care, Health and Social Care Board. Thank you, Michael.
Thank you for that. Hello, everyone. Okay, I have a very short presentation. Shouldn't take too long to go through. So I really just picked up from the information I was sent what I think you want to hear. But obviously at the end there's going to be the opportunity for questions. So if there's some aspect to this that doesn't cover what you want to talk about, there's absolutely no problem. We can get into that. So could I have the next slide, please? So what I have here, and you know, some of these slides can be a little bit tricky to follow. So I'll talk you through this a little bit. The blue line is the activity in general dental services. That's primary care dentistry, your average high street dental practice, back in 2019. So we're setting that at 100%. That's the pre-pandemic activity. The red line is what happened in 2020, and then you have each week of 2020 along the bottom there. So we were trundling along quite rightly until about week 11 or 12. So that takes us through into March. And towards the end of March, then when the pandemic started to hit, Northern Ireland started to hit the UK and Ireland, we had to implement very strict infection control procedures across the health service, across primary care, but particularly in general dental practice. Now, you will know yourselves as patients that general dentistry is very up close and personal. You're only inches away, patients are only inches away from the dentist's face. A lot of the procedures are aerosol generating. So whether it's the drill is being used for fillings, that terrible whining sound, or for scaling and polishing, to have your teeth cleaned, again, there's an aerosol generated there. So about 75–80% of all dental treatments generate an aerosol. And because the coronavirus is a respiratory virus and it is transmitted in the air and in aerosols, if you're generating an aerosol in the oral cavity, you are increasing the chances of spreading the virus. And actually, recent results published in Canada, they ranked every profession by the risk of transmitting or catching coronavirus, and dentistry, dentists, dental nurses, dental hygienists, they are the top three, the most risky thing that you can do to put yourself in the way of catching COVID-19. So we had to be very particular about the infection control procedures that were followed in dental practice. And this is the same in Northern Ireland, England, Scotland, Wales, and the same in hospitals, in general dental practice, in community dentistry, out of hours dentistry. Everybody was following the same standards. But what that meant to start with was that there was an enormous drop-off in activity. So the initial measures were very strict. There were no AGPs permitted, and it was only urgent cases until well into June. Thereafter, we were able to ease restrictions a little bit and still didn't allow aerosol generating procedures, but we were able to do non-urgent cases. And that takes us to the little increase in the red lines you start to see about week 27, 28. A little bit later then in July, we were able to allow AGPs to be carried out in general practice and allow non-urgent cases to be seen, because by that stage we had got the PPE to practices and practices had been able to source the PPE. So we gradually see an increase in activity really around about sort of September, October. It starts to plateau, and that is the level of activity we have been at, 43% of historical pre-pandemic activity. When you see the green line, that is this year. And it does vary a little bit depending on the time of the year, summer holidays, and then there's a bunch of claim forms that are submitted after the summer holidays and those types of things. But by and large, the average of 43% has remained since then. And that is where we are now. Now, just in September, we changed the remuneration arrangements for dentists to incentivize more activity. So we have started to give dentists a particular fee if they use the higher level PPE. And we have also upped the minimum thresholds that they need to perform at in order to, if they fall below a threshold, they get penalised financially for that. So we've upped those levels to try and increase the average level of activity above 43%. We haven't got the results of those changes through yet. Hopefully they'll come in the next week or so and we'll know how effective that is. All the time this has been happening, so we've modified the remuneration arrangements in dentistry to try and get dentists to see more patients, to try and make sure they're covered for their additional costs. All the time that has been happening, the IPC requirements have been relatively steady, certainly for the last year. However, just in the last month or so, we're starting to see consultation documents coming out across the UK that are indicating that the infection prevention control requirements, the IPC requirements, are going to be eased. It isn't a done deal yet, but that looks to be the direction of travel. So perhaps in the next month, we will see an easing of those restrictions. An easing of those restrictions would mean that activity could be upped really quite significantly. And so that would allow us to start clearing the backlog. It would allow us to start widening out the patient groups we're seeing, because we're very much seeing high priority patients, high priority treatments, patients in pain, patients that got long-standing problems, children that maybe have crowded teeth and may need to be examined quickly before damage is done if they're not seen quickly. Those types of things, we've been using our scarce resources to the optimum effect at the moment, but an increase in activity would really be a great boost to the service and to the population. So we're crossing our fingers that this is going to pan out to be a reality, this reduction in infection prevention control procedures. That'll be known in the next month or so, as I say. So we're doing our very best to increase activity. I should also point out that to complement what was happening on the high street, we did open up one in every trust area, an urgent dental care centre, and they were coping with those patients that couldn't be seen on the high street for various reasons, whether the patient was actually COVID positive or suspected COVID positive, or in the early days of the pandemic when we couldn't do aerosol generating procedures on the high street, this is where the patients had to go. Now, we were operating those sites 5 days a week up until the autumn of last year, but as the high street practices started to increase their activity as per the red line on your graph, we didn't require those urgent dental care services to the same extent. So they have been complementing each other. So the urgent dental care centres have turned down their capacity a little bit as the high street capacity has gone up. Could I have the next slide, please? This is just to give you the background of the overall trend in population oral health in Northern Ireland. So up until the beginning of the pandemic, we have survey results from 2019, which aren't yet published, but I can tell you that if I were to add them into this graph, it would be around 30%. So these are the average number of 5-year-old children in the population who are affected by decay, regardless of whether that decay is treated or not. So they could have a filling, they could have a cavity, or they could have had a tooth taken out due to decay. So back in the 1960s, when no one in this call was born, dental decay levels were astronomical in Northern Ireland. 90% of the 5-year-old population had dental decay. But over the years, it's declined and declined, so that, as I say, in 2019, if I put the bar in for that, it's about 30%. And we're still not the best in the UK. We're not as good as the Republic of Ireland, but we have improved dramatically over the last 17, 16 years or so. And that's because we've put in place programs which target young children in preschool settings, in primary 1 and primary 2 classes. That's where we're going to get the biggest bang for our buck. And we've also targeted children in deprived areas. Next slide, please. And this just shows you the challenge that we face in relation to dental health inequalities. So this is a survey that was carried out some years ago, but you can see that children in the most deprived parts of Northern Ireland, they're looking at decay levels which are 3 times those, more than 3 times those of children in the most affluent or least deprived parts of Northern Ireland. And that is a real challenge for us. What you're really getting here is that ultimately the deprivation results in behaviors which increase the likelihood of the dental decay. So a poorer diet, a diet high in sugar, frequent sugar intake, children who are drinking a lot of lemonade, a lot of sugared drinks, eating a lot of sweets and sugary snacks between meals, they are really what drive decay levels. You're also dealing with, the social aspect is very important. So there can be, you may be dealing here with children from migrant families. You may be dealing with children where there's disruption at home, and a healthy diet is a struggle for the family. You may be dealing with families where benefits are hardly enough to meet needs. So there are a whole conglomeration of factors which sit beneath these very bland figures here, but deprivation and the oral health problems that go very strongly with deprivation are a real challenge for us. How we deal with that at the moment is we target our resources as much as we can at these groups, but sometimes that's not enough. In other parts of the UK, they have been able to get funding for almost like social workers with an oral health agenda, and that has proven to be really quite effective. So that is something that in the new strategy that we're developing for children's oral health in Northern Ireland that we're trying to push forward. That hopefully that strategy will be issued in the next 3 or 4 months, and that will hopefully be an element of it. So there's a realization that these problems are outside of the health service and extend into the broader society, as it were. Next slide, please. One of the things that's important about dentistry and distinguishes it from general medical services is that you have to be actively registered, and your registration is time limited. And historically in the Western area and in your council area, levels of registration were lower than the Northern Ireland average. However, when we look at the figures in recent years, we've seen a very significant increase. So it's not a very clear chart, and I apologize for that, but if you look towards the right-hand side, the 2 red bars, you can see that regionally there's been an increase from around 60% to around 70% in that 13-year period. In the Western area, the increase has been from about 57% to a little bit over 70%. So the increase in registration for, and I'm assuming that's, hang on, I'll have to check for children has been greater in the Western area than it has been across Northern Ireland as a whole. So that's as a result of activities to drive forward access to dental services, which have by and large proven to be successful. However, this is all against the backdrop now of the pandemic, where being registered doesn't guarantee access. So hopefully, if we start to see the improved levels of activity, these access levels or these registration levels will translate through to increased access for the population in your area, much closer to the Northern Ireland average, which, as I say, in historical terms, would be quite a marked improvement. Next slide, please. And this is for adults. And again, it's a very similar pattern. If you look towards the 2 bars on the right-hand side, the average for adults across Northern Ireland in 2008 was markedly better than it was for adults in the Western area in 2008. That's the bar on the extreme left-hand side. So you were starting from a lower base there, but now that gap has closed quite markedly, so that in the Western area, you're sitting at about 60% now, and across Northern Ireland, it's about 65%. So the difference between where the Western area is and where Northern Ireland is as an average, they're much closer. They're much closer together. So there has been progress made in trying to secure and improve registrations for patients in the Western Trust area and in your council area. But as I say, the pandemic is distorting things at the moment because we just cannot get the number of patients into the surgeries that we would want to. Next slide, please. That's, as I say, all the slides I have, but I'm very happy to take any questions on that or any other aspect of dentistry or oral health.
Well, thank you very much, Michael, for your very interesting presentation. A very comprehensive presentation indeed. Okay, there are several people want to come on here. And first is Councillor Anne-Marie Fitzgerald, I think it is.
Yes, that's me. Thanks, Earl, and thanks, Michael, for your presentation. I know I suppose a lot of people out in the community, they're wondering, and which is maybe why the takeoff is so low, is can we go now for just a general checkup, or is it just for a film? I know for a long time people was just looking to keep the general yearly dental checkups, but I know within my own home it's been quite a time. So, and we didn't want to pester the dentist. We have a good relationship with our dentist. That's why we've intentionally stayed away, and as other people has. And then the other one is just emergency dental care, either late in the evenings or at the weekends. And I know it's a huge issue. I know a few people in deprived areas who have no access to cars, and they've been told the nearest A&E unit is Craigavon to go to get any.
Okay. I'm happy to cover both of those. So in relation to the routine examinations, it does vary from practice to practice. So some practices, particularly those practices whose patient list before the pandemic, they had a very low levels of dental decay. they came through the pandemic very well, and even with 43 or 45% activity levels, they were able to clear all the patients that had urgent needs and then have capacity to see those patients who were a lower priority, those patients who wanted an examination, a checkup, a scale, and polish. So there are some practices in that situation, but most practices aren't really, and particularly those practices in deprived areas, or those practices where their catchment had a population with reasonably high disease levels. They have had to devote all their 43% capacity to managing patients with an urgent or a pressing need. And we do insist that they must prioritize. They've got to work through the patients who are in pain, who are going to end up in A&E if they don't get seen quickly. So we are quite strict with them in terms of the guidance that we would issue and expect them to follow. So I'm afraid at the moment we are still dealing with quite a number of practices who are still in the, I would say, maybe not urgent territory, but pressing patients who actually have things that need to be done that are causing them problems. But if we get this easing of infection prevention control restrictions, then we would be, for most practices, into the territory of routine examinations. And that would really be important for children and for people who have a history of recent levels of recent decay, or people who would be perceived to be at risk from oral cancer, older people who are smoking, older people who are consuming alcohol beyond the recommended limits. So there are priority groups, and we are issuing updated guidelines to the practitioners that not only should they be seeing those who are having symptoms, but they should be extending their priority list to include those who are at risk, such as those groups of children and older adults, and really anybody in the population who's at risk of developing dental decay or dental problems between their last appointment and now. Just to pick up on your second query then about the emergency dental services or the out-of-hours services. So in the Western area, there isn't a dedicated out-of-hours centre, and in fact, really none of the out-of-hours arrangements are operating now during the pandemic as they were prior to the pandemic. So there aren't really any standard relief of dental pain clinics. We just have the urgent dental care centres, which are primarily for COVID positive patients or those suspected of COVID, or unregistered patients who can't get care anywhere else. You're right to say that those are limited in number. At the moment, there really only are 3 sites that are operating, one which is on the St. Luke's site in Armagh, one which is in the Carlisle Centre in Belfast, and one which is in Dalriada Urgent Care in Ballymena. And they are the 3 sites we have that cover the whole of Northern Ireland. How we've been dealing with patients who need urgent care is we have been incentivizing and encouraging the practitioners to make sure that even if the patients aren't registered, that they see them. And not all, but a lot of the practitioners are doing that, are trying to do that. But it is a problem with this reduced capacity trying to fit those patients in. There are also in the Western area, there are practices who group together into rotas and will provide out-of-hours care for patients who are in that rota. They are not operating to the same extent as they were prior to the pandemic. But I think if we see this reduction in infection prevention control measures, we could be looking at a reactivation of those rotas, and that would be the main facility for patients experiencing problems out of hours to receive the care they need. So at the moment, we are a little bit patchy, I would accept that, but hopefully within the next month or so, we can see something closer to what we would have enjoyed in the past.
Yeah, because we're seeing patients going to A&E departments, which are already full, and it's not the place for them, you know what I mean, to go with any emergencies. And no, it's not good, but hopefully that maybe going forward, it'll be a better forward approach or whatever. But thank you, Michael. I appreciate it.
Okay, thank you very much, Michael, and thank you to Councillor Fitzgerald. Next up, we have Councillor Barry McElduff. Barry.
Chair, during the middle of the pandemic, I recall meeting in John Street, Oma, one day, a dentist out for a walk, and he told me that he had been diversifying. At that time, there was no business, there was nothing happening, and he told me he was doing a bit of farming. I thought that was as a memory I carry anyway. But I think Michael's presentation was very good, very helpful. And it's something we needed to understand, is the strategy coming out of the pandemic and all our worries for people's, dental decay and all of that. I suppose the presentation spoke for itself. It doesn't invite too many questions, but one general question I would ask Michael is this. Is it legitimate for a dentist to say to a patient who has been with them for many years, and this is a constituent of mine who contacted me, they've been with a dental practice for years. Their circumstances changed where they ended up on universal credit, etc. And the dentist then said, sorry, I'm not taking on any new NHS patients. And the constituent couldn't understand it because they weren't new to the practice. They had been there for years. Their circumstances have changed. And that person had to find the money to pay the bill when in fact they should have been receiving NHS, support. But the dentist said not taking on any new NHS patients. And there was a tension developed then between the patient who enjoyed that dentist practice for years and the dental practice.
Okay. Yes. So the devil could be in the detail here, Councillor McElduff, in that it depends. This thing about registrations lapsing. So it depends whether the patient's registration had lapsed, and in the normal run of things, you're registered for 2 years if you don't attend, and then after that, your registration lapses, and you could be treated as a new patient after that. So it does depend whether their registration lapsed and then the practice or practitioner decided to view them as a new patient. But if their registration hadn't lapsed, then you can't you would have to go through a process in order to move a patient out off your list, which requires some correspondence to be sent to the patient explaining what's happened. A 3-month period has to elapse, and thereafter you can deregister patients given that period of notice. It doesn't sound like that has happened here. Otherwise, the patient would have been aware through the letter that they received from the dentist. So their registration may have lapsed and they may not just have realized. Nobody, you wouldn't necessarily be informed if your registration had lapsed. Now, one of the sort of vagaries of health service dentistry in Northern Ireland is the ability for dentists to move between health service dentistry and private dentistry. And the vast majority of dentists do some amount of private dentistry, and it's a spectrum from they do 1% of their time private dentistry through to 100% private dentistry, and most dentists lie in the middle, probably spending around 2/3 of their time on health service patients. But they do operate in that way, and that is within the rules. And we try as a board to ensure that patients have health service access. Now, at times we have had to intervene, and that happened prior to really around 2010, when the economy in Northern Ireland was strong, and a lot of there was more disposable income, and patients were willing to pay privately. And so, for example, in Enniskillen, we set up Oasis Dental Care were the contractors, and they provided health service dentistry to many thousands of patients in Enniskillen at that time. That was a 5-year contract, and by the time the contract was up, the global economic downturn had seen to the buoyancy of the Northern Ireland economy and the amount of disposable income, and health service dentistry returned with a vengeance. But the pandemic has distorted things again in a number of ways, and we are beginning to see what appears to be a rise in private dentistry. So because the dentists can move, can vary their practice, they're able to do that. And it may be that the person you're referring to has been caught up in that type of thing, a practice that is shifted from being 90% health service to 50% health service, or something like that, and they've taken the opportunity of not accepting back patients whose registration has lapsed. So that sounds to me like what has maybe happened there.
Okay, thank you,
Yeah.
Chair, and thanks, Michael, for that.
Okay.
And Chair, I'm going to have to take me leave, and I do have a matter with probably Alan Moore that is listed on the agenda. Alan may or may not be here, but I undertake to ring Alan Moore's office tomorrow, about it's a matter at the Oma Hospital car park, it's like an access issue, so I'm guessing it's the
Yep.
states. Okay, thank you, Chair.
Thank you very much, Councillor McAuliffe. All the best. And thank you again, Michael. We've just got a message on chat
Chair.
there.
Sorry.
Sorry, we've got a message on the chat line there from Dr. Kieran McLaughlin. She's had to leave, but if there are any other questions, she's happy to take them online. So just leave it at there. Next up for Michael is Councillor Victor Warrington.
Yeah, well,
Sorry, before you come on there, Victor, sorry about that. Teresa, I think you're maybe trying to get on there.
It was only to just advise Councillor McElduff that Alan Moore has retired, but that estates matters in relation to the car parking issue are my responsibility.
Right, Teresa.
So if you want to either ring or drop me an email, Councillor McElduff will deal with it. Thank you.
Thank you, Teresa. I'll definitely contact you tomorrow, and thank you.
Okay, we'll just next up we'll have Councillor Warrington and followed by Councillor Josephine Dehan. We'll take those comments together to get this piece closed in. Thank you.
Well, mine just as a comment, just to say what was described there. I've actually first-hand knowledge of where I let my own dentist lapse, and when I went back to them, they had basically they weren't taking on any more NHS patients. Would have taken me on privately, but they weren't taking on any other NHS patients. So I sort of can see where Councillor Michael Duff was coming from there.
Thank you, Councillor Warrington. Moving on now to Councillor Dehan. Josephine.
Thank you, Chair, and I want to express my thanks to the delegation that has joined us for our subcommittee meeting this afternoon. Thank you for giving of your time, for preparing answers to our questions, and for reassuring us on the services that you provide. I want to thank Michael in particular for his presentation, and it is heartening to see that general dental registrations in the Western area have really risen to such a good level, and that's to be welcomed. I suppose overall, though, we still would be concerned regarding the high levels of dental decay, which we see in our district council area. And I am still getting letters from our community dental officers saying your patient was admitted and had so many extractions under general anaesthetic. And these are very young patients. And in my view, in this day and age, that sort of thing really should not be happening. I recall when I became a councillor first, a long time ago, we had what was called an oral health strategy group, which met every quarter, and we looked at measures that we could take to improve dental health and hygiene amongst children. And there were visits to primary schools and free toothpaste and toothbrushes, and I thought, and just generally getting children excited about their dental health. I just wonder, does that still go on? And if so, what resources are put into education on dental health and so on. Generally, I would like to see measures put in place that would encourage general dental practitioners to spend more of their time treating NHS patients. We have discussed this in council on more than one occasion, and we had queries regarding the remuneration that dental practitioners get for NHS work and how it compares with that when they treat private patients? And also finally then, you know, is there a quota system for dental practices in terms of their NHS work? You know, is there a quota, an upper limit of remuneration that they can get, or is it open-ended? Thank you so much.
Thank you, Commissioner Dahan. Okay, Michael.
I'm happy to work through those. So yeah, I mean that sounded really good when you had the oral health group back in the past. But yes, we do have various initiatives targeted primarily at young children and also at children in disadvantaged areas across Northern Ireland, and it happens in all council areas. There were about 60,000 children prior to the pandemic that has really stopped these schemes because of the close contact that would be involved. But we would have had 60,000 children, those in preschool and those in primaries 1 and 2 across Northern Ireland, who would be involved in generally supervised toothbrushing, which probably has about the strongest evidence to support it with a fluoride toothpaste. That was the sort of core scheme that we would have used across Northern Ireland, although there are a few variations on that. There's also a role for general dental practitioners. There was a big study done, a big UK funded study. It was done in Northern Ireland about 5 years ago, and it was about using a fluoride varnish to apply to the teeth of very young children, those aged 2 to 5. And that proved to be successful, and now general dental practitioners will do that as well in those children who are believed to be at risk of dental decay. So things can happen in practice as well, but all of these things really could be enhanced, you know. And so I mentioned earlier that there's a departmental group looking at an oral health strategy. It's an oral health options group, it's called, for children. And these would be very much key ideas that would be, you know, likely to be recommended by that group. So an extension of those sorts of schemes, investment in those areas. You know, I think that there's a strong evidence base to support that type of thing. Just picking up a little bit more on your other points then, in terms of remuneration levels in health service dentistry. Yes, I mean the data on that. There's NHS Digital produce annual reports, and they do paint a picture of declining remuneration. It's quite difficult to disentangle some of the data because the amount of hours worked is less now than it was, say, 10 years ago. The clinical time is maybe less because the administrative end is, and I know that my GP colleagues will appreciate this as well, is so much more time consuming. So even though they're at work for the same amount of hours, the amount of time they can devote to seeing patients is less. So these are the sort of, and it's seeing patients in general dental practice, which is how earnings are generated. So these are the sort of effects that are going on. But I do know from talking to my colleagues in general dental practice that there is a considerable amount of discontent about remuneration levels, and that is obviously something for the Department of Health. There is a group, a rebuilding stakeholder group made up of representation from the BDA, the department, and the board, which is looking at contract reform, and that obviously would be a key element of any new contract. It's something that the profession would dearly love to see. So that's ongoing. And your other question about a quota system or an upper limit, no, it's the way that general dental services work. It's a demand-led system, a demand-led contract. If the dentist is prepared to work 7 days a week, they can work 7 days a week. If they can treat, 50 patients a day, they can treat 50 patients a day. We monitor the quality of the care. We examine a proportion of the patients to ensure that the work has been done properly. But they can work, as many hours as they feel able to do. So it is quite flexible in that regard. But the tendency has been for increased part-time working rather than additional hours. So maybe back 30 years ago, you would have had people putting in heroic hours, maybe not necessarily healthy working hours. That doesn't help. That doesn't happen to the same extent. People tend to work more reasonable hours now, and so whilst we've seen an increase in the headcount of practitioners, I know again this is a GMS phenomenon as well. The whole time equivalent has not enjoyed the same percentage increase, although it has gone up a bit.
Thank you. The reason I asked Chair about quotas is because my daughter is a general dental practitioner in England, and they do have a quota system there, and they are contracted to provide a certain number of units of NHS care, and if they exceed that, then they're penalised, which seems a disincentive. But I certainly would like to see general dental practitioners remunerated properly for the NHS work that they do, because if they are not, then understandably they are going to go towards private practice, and that is not, in my view, in the interests of the general population. So thank you. Thank you, Chair.
Thank you very much, Councillor Dehan. Thank you, Michael.
Thank you. Thank you, everyone.
If you can take down your hand now, Councillor Dehan and Councillor Warrington. Councillor Warrington. Yeah. Okay, sorry about that, folks. Just getting a message that the trust team are leaving at 5 p.m. So I'd like to thank, first of all, the Health and Social Care Board team representatives for coming on here today and for their presentations and for taking the Q&A. So thank you, and I'll let you leave the meeting now. All the best. We now go to item 6, and that is to receive a response from the Public Health Agency, the following matters raised by members. And 6.1, the rollout of walk-in vaccine clinics in the council area and the inadequate supply of vaccines at recent walk-in clinics, aimed particularly at attracting young people. And on the line here we have Mr. Aidan Dawson, Chief Executive of the Public Health Agency, and you're very welcome, Aidan. So over to you. Thank you.
Thank you, Chair. Excuse me, I have a bit of a croaky throat at the minute. I think it's probably appropriate to say at the start, Chair, that and council members, that I'm not responsible for the vaccine programme across Northern Ireland. I do sit on the vaccine board. It is run by the Department of Health, and the walk-in clinics are the responsibility that sit within the trust, and they are probably better placed to answer this question than I am. And I wouldn't want to take that away from Neil and his team, that I'm speaking on their behalf this afternoon. So I just thought from the outset it was important to set that in the context of anything I might say. I also felt it would be rude not to turn up and send the message to that effect. So I'm always quite happy to engage with councils and councillors at a local level. Just in the broader context, I would say that whilst they are, the walk-in clinics are hosted and run by the local clinics, I do understand that the walk-in clinics are difficult to judge. They have been rolled out since July very successfully, and it is difficult to judge when you're setting them up. There's the weighing up against scarce healthcare resource in terms of manpower and people to actually go and run the clinics, but also the vaccine itself is a very delicate thing and very expensive, and wastage is an issue if you bring too much. So it is difficult to plan for walk-in clinics when you don't have booking in advance. At least if you have bookings, you know how much exactly you're going to use within a period of time. So I do realise I suppose the things which the trust take into consideration when setting them up. I understand where there have been difficulties at specific local venues that the trust have undertaken to return at a very early date and provide a second clinic or more to ensure that they provided that successfully to all those that wanted to avail of it. I believe there's been high attendance also at second dose clinics, which are booked for those that have had first doses. And there may have been an issue around the fact that people have turned up believing that they were walk-in clinics, and that's not the case. But again, I understand that the trusts are perhaps making an adjustment around those to provide additional second dose clinics, including this weekend going forward. I think it's probably also important to reflect on a very significant success of the vaccination plan in the Western Trust, particularly on the localised mobile vaccine planning arrangement since July. Based on the department COVID vaccine plan, there was originally 3 large vaccination centres, but in recognition of the dispersed rural population to be served from those large centres across Libavady and into Fermanagh, there's been a close liaison with the councils and others to promote vaccine uptake. From late July 21, the Western Trust have proactively used the low vaccine uptake data provided by ourselves in the department to target the mobile vaccination clinics in community settings where vaccine uptake was lowest. And for Fermanagh and the Omagh District Council, we know that low vaccine uptake areas included Lisnelly, Owen, Coyle, Thurman, Domaskilly, Dromore, 6 Mile Cross, and Killyclogher, all below 40% vaccine uptake, where the average across Northern Ireland was 55%. The mobile clinics that were held across the area, and then by the end of September 21, the vaccine uptake data shows that the lowest uptake has risen to 63% from that low base below 40. In the lowest uptake area of Fermanagh and Omagh, Lisnelly, the low uptake areas identified in early July had all increased to an uptake of between 67 to 73%, which is a huge success. And I think councils and the trusts are to be commended in their efforts to do that. I should also say, given the rural community in the West, the region has learned from the approach of the trust and its partners, and that has helped us in terms of developing a strategy across the whole of the region for Northern Ireland. And we should recognise that over 5,500 people in the Western area have received first dose vaccine through the mobile clinics, and the confidence and engagement has also positively encouraged those in low uptake areas to present for vaccine opportunities, either through the mass vaccination centres or the community pharmacy. So I mean, that's a sort of short response to the question that was asked, and I wanted to come and give that. As I suppose, as I would say, Chair, the operational issues are really for the trust to come back. I just sort of give the generalisation of that. I don't want to speak on behalf of the trust because that is their operational responsibility, and it'd be inappropriate for me to step into that space. But I think there has been really good uptake, and people have been encouraged, and I think there has been good leadership given in the region. So,
okay, Aidan, thank you very much for coming on this afternoon and stating your case. I'll ask members to be very brief with their questions and comments because we have to go to the Western Health and Social Care Trust. So first up is Councillor Warrington. Victor.
I will be brief, and maybe this is not under your remit. Aidan, I think it was. Yes. Yeah. Obviously we're now in a case where a lot of people have had their second jobs quite a while now. The booster jobs, it's my understanding that they are going to be rolled out through the general practices in the areas. Obviously, those people who originally had got the Pfizer vaccine, we all know that the Pfizer vaccine needed quite a different storage from some of the ordinary vaccines. So those persons going for a booster sooner rather than later, what can they expect? Like obviously the GP practices won't be rolling out with the Pfizer vaccines. Is that correct?
My understanding, and it's different for different practices, but I know that some of the practices across Northern Ireland will have large enough quantities to be running Pfizer vaccine. I think also from the community pharmacy point of view, they will predominantly run with Moderna and Pfizer. I think, Maurice, is that correct?
Primarily, so an additional cohort of community vaccine pharmacists, about an additional 100 pharmacists have all signed up to provide the booster vaccine, and that will be Moderna in the first instance, with a potential for later down the line of applying Pfizer. But there are issues to be resolved, but it will be primarily through community pharmacy, where community pharmacy are providing. It'll be Moderna.
And obviously, I'm getting feedback here. The Moderna vaccine obviously bounces off the Pfizer vaccine. Okay, then is the booster? I take it. I know that's probably a stupid question because you wouldn't be rolling something out that's going to kill us.
Yeah, no, I don't think any questions are stupid questions, because there's always questions around COVID and boosters and the vaccination. But my understanding is it is perfectly okay to have a different type of vaccine from the primary one that you got.
Thank you.
In terms of top up or booster.
Thank you.
Thank you, Councillor.
Sorry, I don't know how I was muted there, but there you are. Thanks to Councillor Warrington and thanks to Aidan and Morris, I think it was there, answered that. So without further ado, I don't see anyone else indicating, so I'll let you go, Aidan, if that's okay.
That's
Thank you very much.
fine.
Thanks
Thank
for
you
taking
for your
part.
time this afternoon.
Thanks, Morris.
Sure.
Thank you.
Thanks, bye.
Okay. Okay, members, we're now on to item 7, and it's to receive a response from the Western Health and Social Care Trust to matters raised by members. And first of all, can I, at this stage, welcome to his first meeting of the Fermanagh Health and Social Care Services Subcommittee, Mr. Neil Guckian, Chief Executive, the new Chief Executive of the Western Health and Social Care Trust, and all of his team who have joined us this afternoon. Neil.
Thank you very much, Chair. I look forward to, first I'll introduce myself. My name is Neil Guckian. I'm taking over as Chief Executive of the Western Trust since the 1st of July. I have been in the Trust for a number of years, but I haven't had the wonderful experience of joining you in the Fermanagh Council. I just want to say that I look forward to working with you in what will be a very challenging period coming up. All I'll say is we will always do our best to serve the patients and clients that we come into over the coming period. And I would just like to pass over to Geraldine, who will be hosting this afternoon. I will have to go at 5. I have another meeting at 5 o'clock, but I'm sure hopefully we'll get most of our stuff wrapped up by then.
Well, thank you very much, Neil, for joining us, and I'm conscious that you all have to leave at 5 p.m. So we'll keep it very succinct and to the point. So over to you, Geraldine. Thank you.
Okay, thank you, Chair. And with me today, as well as Neil, I have Teresa Malloy, Director of Performance and Service Improvement, John McGarvey, Assistant Director for Primary Care and Older People, who is representing Bob Brown, our Director of that service, and Tom Cassidy, who is Director of Women and Children's and our Executive Director of Social Work. I think I've got everybody that should be with me. And if we just maybe start with the 5 areas, the queries that you had asked for. The first one, Teresa has agreed with Councillor Michael Duff to take offline and discuss. So happy with that. The second question is in relation to the referral times for CAMS and the process for the transfer of cases in the event of a member of staff leaving a position to avoid delays in the provision of service. So I'm going to ask Tom to take that, please, for me.
Geraldine, thank you, and thank you, members, for your interest in this. I mean, I'll just run through the actual the waiting list or the processes. So, for instance, if there's an emergency referral, it will be seen within 24 hours. If it's urgent, it was seen within 5 days, and if it's routine, it should be met within 9 weeks. However, we meet the target with respect to emergency and routine referrals, but we have struggled for quite a period of time in relation to meeting the 9-week target due to demands on the service. And I think previously at the last meeting, I was saying about the increase in referrals to the CAM service, particularly in relation to the more acute mentally ill issues. So that is referenced in this one. But all referrals are screened and clinically triaged and monitored on a weekly basis to ensure timely response to routine cases, particularly if a young person's mental health deteriorates. In relation to the sick leave aspect, when a staff member is on extended sick leave or leaves the service, the caseload is immediately assessed in relation to how urgent it is, how urgent the cases are. The families are contacted, and priority is given to the most vulnerable young people. We hope that this ensures timely response to the most needy of young people, and it also means that, unfortunately, that some other children and young people will have to wait longer for intervention. But we have looked at our service, and we have over a period of time reduced our waiting times, and all measures that we try to take, apologies for that. All measures that we try to take, including consideration of some of the voluntary services such as Youth Life, which is contracted to the service to help us deal with that more routine demand, which we are conscious of in relation to waiting times. So that's basically the situation in relation to the referral times and when someone leaves the service. But I'm more than happy to try and take members' questions if you felt it would be appropriate.
Okay, thank you very much, Tom, for that. And as I said at the outset there, folks, I want you to be very short and sweet and to the point, very succinct on this one. First up is Councillor John Coyle.
Thank you, Chair. No, I submitted this question and I have liaised with Neil's office on, in relation to a constituent just using this service. So I will await a response to it for that client. But no, thank you for it, for the update. And it's just, relevant that, that maybe the ball isn't dropped when dealing with cases like this, that if a staff member does move on or moves up in whatever case, that that their cases are taken on board. And thank you for the update.
Thank you, Councillor Coyle. And
I just want to say, Councillor Coyle, again, thank you for your interest, and we'll certainly come back to you and relate to that specific issue that you've raised with Neil, our Chief Executive. It is something that we are very conscious of, and we are aware of the increase in issues in relation to young people's mental health, particularly throughout the COVID period. So thank you.
Thank you, Tom. Thank you, Councillor Coyle. Next up is Councillor Josephine Dahan.
Thank you, Chair, and I too want to convey my congratulations and best wishes to Neil on his appointment as Chief Executive of the Western Trust. We wish you all the best in your work in what I know to be a very challenging role. Thank you, Tom, for your update, and I appreciate all the work that is carried out by the CAMS team. And, you know, speaking as a primary care physician, and I'm sure I speak for many of my colleagues, you know, when it comes to treating children with mental health difficulties, you know, we rely very heavily on the secondary care services because we are not able, we do not feel competent to prescribe for children and young people. So we're very much reliant on the CAMS teams. And we appreciate the work that they do in keeping our young people safe. And there has been an explosion of mental health difficulties amongst children and young people. And, you know, it is a matter of great concern to all of us. My question really relates to, and I'm sure this is a question that has been asked on numerous occasions, in terms of diagnostic services for ASD and ADHD. And of course, you know, a child or young person must have a diagnosis before they can access many services. And in my experience, practically, you know, the waiting times are excessively long and cause great distress, not only to the children and young people, but also to their parents. And families have to rely increasingly on the voluntary services, and we definitely appreciate the contribution that they make. You know, organizations like Action for Children and all the support that is given there. But really, I mean, I want to ask what measures the Trust are putting in place to reduce the time to diagnosis for these conditions. Thank you.
Thank you, Councillor Dehan.
Thank you, Councillor Dehan. I mean, again, we are very conscious of the waiting times in relation to autism, and I think this has been something that has been, you know, something that we've been worried about collectively for quite a period of time. We have looked at our the pathway for autism services, and we've brought in a number of processes that will improve it, we believe. However, I mean, I have to say again that the demand will continue to outstrip supply, unfortunately. But some of the things that we try to do are when open the sort of triage line so that families can contact us whilst they're waiting for a service, offer them practical support in relation to doing that. And also, you mentioned the voluntary and the community sector through the outcomes group, Councillor Dehan. I think, am I right? You're a participant in that. You know, we have looked at trying to engage in some of our locality groups in relation to, you know, understanding the issues in relation to autism. I think at the last outcomes group, a number of this was raised by a number of the locality planning groups, and Kevin Duffy, who's the assistant director for and responsible for CAMS and our autism services, has offered to meet with these locality groups to help them understand what we're trying to do, but also for us to try and understand, you know, the issues that they're facing as a result of the demand and how we can support them in relation to, you know, offering appropriate advice, etc. So I hope that goes some way to answer your question, Councillor Dehan.
Yes, well, thank you, Tom. And yes, I'm aware of the of those initiatives, and you know, and those initiatives are of great benefit, of great practical benefit to families. But nevertheless, you know, a child needs a diagnosis. You know, they need and they need it sooner rather than later. So that will continue to be the demand from parents and guardians. But thank you for that.
Thank you, Councillor Dehan. Thank you, Tom. Over to you, Geraldine.
Okay, thank you, Chair. Members' query 3 is around the current procurement exercise for the requisition of domiciliary care services, and I'm going to ask John McGarvey, who's here, I think, to lead on that. John.
Thank you, Geraldine. Members, I suppose just to give you the background to domiciliary care, contracts within the Western Trust. We contracted for services in 2017 with an award of a 3-year contract with the opportunity to extend that for a further single year by 2. We've actually done that, so we're probably in year 4 with some of our providers, moving into year 5 with some, going through year 5. We've looked at the service and how it's performed over the course of the last contract period, and the service model has been independently, I suppose, assessed and analysed through 10,000 voices, and there's a very high level of approval rating. In fact, it's been audited twice in the last 5-year period. So we're proposing to go back again to retender for the service. It's an extremely important service, supporting people to remain in their own homes. There are challenges in relation to workforce. Some of the issues that have been highlighted in the motion moved by members, we're happy to meet with the council and discuss those, but we are committed to a contracting and retendering window, which we are legally obliged to comply with.
Okay, thank you very much, John. Councillor Dahan, you still got your hand up? Thank you. Next up we have,
yeah, thank you.
No problem, Councillor Bernice Swift.
Yeah, Gora Magat, Ciarán Anna. I'll start off by welcoming and congratulating Neil and work with us positively in the future. So thank you and good luck, Neil. Thanks, John, for your little brief here. I had asked for this to be placed on the agenda on behalf of Lakeland Community Care Healthy Living. And it is one of the issues, and we moved a motion about domiciliary care services recently within our council. I don't accept, I suppose, the position that you have outlined for all of the reasons that Lakeland Community Care, I suppose, challenge and rebuke on behalf of the inadequacy, I suppose, that we are suffering in the West. So I would like to take you up on your offer, and Chairman, I would propose that we do meet with immediate effect to discuss this issue particularly and give it the meritorious time that it requires. I'm very aware you're all leaving now in 15 minutes because I could have talked for about a half an hour on this one alone and give an example. I know, please don't. Shut up now, says you heard.
You're all right,
but,
go ahead.
It's such an important service, John, and it's one of the issues that I am lobbied on most now, and I don't exaggerate when I say at least twice a week. And I'm dealing with the gaps in our area, particularly rurally, as you'll already know. You've all received the Healthy Living Centre correspondence. I know it was going to be sent to Neil anyway. I'm sure Madonna has, yes, and all councillors have received it as well. So we are all singing off the same hymn sheet on this one, John. And given what Lakeland Community Care and Dr. Lucia Maguire has outlined, I'm fighting their corner and from that position. And so John, when do you think we could meet? You know, how soon? Because this is a very critical and urgent matter, and I do want to give it strong and robust attention with immediacy today, please.
Chair, through the chair, we're happy to arrange a meeting, you know, in the next week or two. I suppose, right. I mean, the ask to set aside the process, there are opportunities going forward in terms of the executive, for example, setting out that we're going to become a living wage economy, which will be built into the next contract that isn't built into this contract. So there's actually benefits with going out to recontract again. So in terms of looking at pay terms and conditions, there's also a social clause now that has to be built into contracts going forward. So recontracting shouldn't be seen as a threat. There are benefits in actually reviewing our contracts, looking at new clauses, and we're trying to make sure we build all of those in. Because what we need is a sustainable workforce that we can encourage people to come in. We're challenged every day with those issues that you hear from your constituents, so we want to get it right too.
That's great. So our people will speak to your people then, as we say. So we'll be in touch with Chris and Madonna and Neil to arrange the same. In 1 week's time would be better probably than 2 weeks, because I know people are going off for Halloween. Some people have to get on their brooms and things like that, like our chairman there. So all joking aside, I take those little reassurances on board, John, but we remain to be convinced about the reality of them working in our rural area. So thank you very much for that. Gormagat.
Thank you very much, Councillor Swift, and thank you, John. Just to make you aware, that will be arranged, Councillor Swift, and I know you made it a proposal. Maybe could have a seconder there.
Yeah, I'll second it,
Councillor
Chair.
John Coyle, okay. And do you wish to come in now as well?
Yeah, just quickly, no, just to reiterate what Bernice said, and I fully support LCC and what they do in our community. I have been an advocate for, this kind of, the home helps getting the money or getting the fair wage that they deserve, and I will participate in the meeting and a better understanding of what exactly the Western Trust is, and make sure that it is acceptable to our community and to the workers that is for LCC. So thank you.
Thank you, Councillor Coyle, and I think we're all agreed that we have the meeting, so that'll be arranged in due course. Thank you. Teresa? No, sorry, Geraldine.
Yeah, thank you, Chair. So the next two items are my own, and the first one is around the pressures being experienced in our any departments as the social media posts are asking patients not to attend. So I suppose it's really important for me to start off by saying that the pressures remain very high across both emergency departments within the Trust, including pressures on COVID and non-COVID attendances, and then admissions that convert from attendances. Flow through our hospitals is also very challenging at the minute on a daily basis, and we have quite a number of patients each morning waiting for a decision to admit to be transferred to a vacant bed when it becomes available. I suppose the purpose of the social media messaging is twofold. The first is to alert the public when we are under severe pressure and our departments are overcrowded, that they may have to wait for a long time if they attend, and depending on their triage category, it might be important to seek other options. And I suppose the second is to consider all the other options that may be available, and just to say that there are a few that can help. And we have been working really hard over the last year with our primary care colleagues and through the No More Silos work to establish alternative pathways to the emergency department. So I suppose that's the purpose of the social media messaging. Options that are available for the community are a phone first number, and we have had great success in terms of triaging and with advice and I suppose redirecting and signposting patients to other services that might be available. We have minor injury stream, and we have the urgent care and treatment centre at Oma Hospital, where the waiting times may be much reduced depending on your need as a public patient coming through, or it may meet the needs of the person and it may not. So the purpose of the messaging is to allow the public and to afford the public an opportunity to make decisions about where they might want to attend. I suppose it's really important that social media messaging is only when we're in extreme pressure, and we have worked very closely with our primary care colleagues to ensure that the impact of that messaging is not felt at GP land, because we do know there's quite a bit of unease around our primary care colleagues and their ability to, as you heard from Ciara today, to see the volume of patients face to face that they might have done pre-pandemic. So I suppose the final thing that I would like to say is that irrespective of any social media messaging, it is really important that someone in an acute emergency situation, albeit a physical emergency, or someone with a mental health emergency or crisis must and should continue to attend the emergency department if that is the most appropriate place for them. And we do put that out on our messaging as when it goes out. So I hope that answers the question. We continue, as you can see, on a daily basis to experience high volume of patients attending both ED departments, and that's not uncommon across the region. Other emergency departments are also in that space as well, and it is really high demand at I suppose a summer and going into an autumn period, and we haven't really experienced that level of demand before. So happy to take any questions before I move on to the other query.
Okay, probably in the interest of time, maybe we'll take your next piece now, number 5, and then we'll take the questions at the end.
Okay. Thanks, Chair. So the question 5 is around the level of assistance being provided by the GP out of our service to alleviate the pressures in our emergency department. So I suppose I don't have any management responsibility for GP out of our services, but we do work closely with them, and we do work closely within the No More Silos work streams in the local implementation group. So I suppose all I can really say is where they are in difficulty in terms of trying to get shifts covered, and one of the key shifts that they have difficulty covering is between midnight and 8 a.m. Where they have difficulty with that, they normally alert our ED departments and myself to that fact, and we would assess the day and the time and put in place arrangements whereby we may have to put in additional medical staff, etc., to try and cover any additional footfall that would come to our ED departments. But they are part of our No More Silos working group, and we are working closely with them around how we can, I suppose, better manage that footfall together. So they're very supportive, and we have included them in the local implementation group for that reason. They're also managing our Western Urgent Care Manager Phone First telephone service. So at this time, and I suppose they can see for themselves the demand that's placed on ED at any time. So happy to take any questions from any councillors. Thank you, Chair.
Thank you very much, Geraldine, for that. And I'll ask our councillors to please be succinct. And I'll bring in first Councillor Anne-Marie Fitzgerald.
Yes, Geraldine and everybody, you're welcome. I'm going to be very quick, talk quick as I normally do. Social media, I think, does make an impact. We try to retweet it or put it on Instagram as much as we can. God love nurses and emergency departments, you know what I mean? I feel hugely sorry for them because it's getting to be absolutely chaotic, beyond chaotic at the minute. And they're going to go into the bathrooms. I don't think anybody's going to use the bathrooms now because that's where the patients, the only places left for them. There's not much room up the corridors. Just one thing on that, there's a high level of staff, I think, leaving A&E departments. You know, maybe it's because of pressure or whatever, just I don't understand. And I was quite vexed to see in another hospital where nurses had left one area and they've now moved up into the same A&E department, but in a totally different area. And I think that's sad, and I don't know, work can be done on that there. Maybe better entitlements, maybe in our local hospitals to keep our qualified staff there. Maybe it's improved banding, maybe more so than those other hospitals, because we're losing those girls. And I was really quite annoyed, and you know, we give them a hug and say, oh my God, what are you doing up here? So they've taken posts up there, so which is quite sad. And then the other thing is just to make best use of our urgent care centre in Omagh. Is there any way that we can even go to other hospitals and maybe put an out notice, have you an injury such as, and to go to Omagh Urgent Care Centre from Strabane or whatever, just down, because whilst they have numbers, they don't have high numbers, and there's high numbers in A&E departments and in the Skillen that would be seen in half the time if they went to Omagh, you know what I mean? So maybe a bit more restriction, but I know you're doing everything you can, but it's chaotic and it's sad out there at the minute. So thanks, guys. End off.
Thank you, Councillor Fitzgerald.
Thanks. Yeah, thanks, Anne-Marie. And I suppose just to give you the assurance, we're very well aware of the issues with staffing within our ED departments. We have a nurse stabilisation group that within the trust that reviews us on a weekly basis. We have had some staff who have left to go to other things, and unfortunately that's what happens, as you say yourself. I have to say that we're doing a lot of work with the team within our ED departments around what we can do to retain that staff group. We're looking at succession planning. We've looked at practice educator roles. We've looked at a number of different roles, senior nurse roles, banding, increased banding, and other means of trying to support the team to retain the workforce that we have, Anne-Marie. But I absolutely accept it's so disappointing when staff move on and they are under severe pressure. So we will work away with them in the meantime and try and do what we can to ensure that they stay with us.
Thank you, Geraldine. Next up, we have Councillor John Coyle.
Thank you, Chair. I'll be brief. No, thank you, Geraldine, for the update. This question, we worded it in a way that a lot of people maybe in the Fermanagh area probably don't know about the minor injuries unit in Oma complex, and that needs to be highlighted as well. And thanks for the update on the the triage and the telephone, and trying to redirect people. But 8 hours, whatever, 9 hours or whatever, waiting in A&E, and the pressures on staff and everything else. We have to send people to the most appropriate, and as I said, most people mightn't even know that there's a minor injuries unit in Oma, and to be seen in half the time, like Councillor Fitzgerald has said. And the out of hours, obviously extra pressure as well, with seeing patients. It was relayed to me for a constituent that the GP wouldn't allow them into the out of hours for a child, and it had to be seen in the car park, because it had a cough. It's okay. Well, it's probably not okay, but we had good temperatures and everything else, but now coming into the winter, that's not acceptable, and it's just to highlight that, to make sure that doesn't happen again.
Well, as I said, John, thank you for your question. We don't manage, the Trust doesn't manage out of our services in terms of the Western Urgent Care. That's a different employer and service, but absolutely we'll take on board the issues that both yourself and Anne-Marie raised around Oma. And perhaps maybe, Chris, we can look at our messaging for that we can redirect patients and signpost them, although we do, I think, put a line in, but we can review that, John, on the basis of, and Anne-Marie, of what I've heard today, and trying to promote our urgent care and treatment centre better. Absolutely. Prepared to do that.
Right. Thank you very much, Geraldine, and thanks to Councillors Fitzgerald and Coyle. Can you just take your hand down there, Councillor Fitzgerald? Okay, there's nothing else there on that one. We'll move on to correspondence, if any. Is anything else from the members of the Western Health and Social Care Trust?
No.
I'm conscious that we're a minute to go here, folks, so if not, I can probably let you go at this stage. So thank you all. Thanks for taking part, and thank you, Neil. It's good to see you, and look forward to working with you.
No problem. Look forward to working with you all. Thank you very much for your time.
Thank you. All the best now.
Take care, everybody. All the best.
Bye. Thank you very much.
Okay.
Sorry, Chair. Sorry, Chair.
Yeah,
thank you. Chair, I see that Councillor Warrington has declared an interest as a member of the Western Local Commissioning Group. I hadn't intended to declare an interest, but just in terms of public perception, could I at this late stage declare an interest as a member of the Western Local Commissioning Group, also as a member of the board of the Southwest GP Federation and the Western Areas Outcome Group? Chair, I didn't take part in any discussion regarding the GP services, so I just wanted to record that, just in case of public perception regarding conflict of interest. So thank you for that, Chair.
Well, thank you very much, Councillor Dahan. That's noted. Thank you. Yeah, I'm being advised here by the Chief Executive. We'll take matters arising now before correspondence. I was going to do it the other way around, but I've been advised accordingly. So matters arising, page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, and page 9. Okay, nothing arising. That's good. Okay, thank you, Councillor Warrington, for the message there. Okay, and on to correspondence, if any. No correspondence. And on to any urgent and relevant business. No, no one's raised anything with me, so I'm going over to the Chief Executive, who has an item.
Yeah, well, Chair, it's really just a reminder for members because of particular relevance to this subcommittee. On Thursday, the 28th of October, we have an informal meeting with the representatives from the Royal General College of General Practitioners and the British Medical Association. So Dr. Lawrence Dorman and Dr. Alan Stout will be in attendance at that meeting, and that's following on from Council's representations regarding various concerns, again, about GP access. So that's an informal meeting to which all 40 members will be invited, Chair.
Thank you, Chief Executive. Don't see any issue with that. That's fine. Thank you for that. Now down to if there's any confidential business. I don't think there is. There's no confidential business. So with that, can I just thank everyone for their attendance. We're a wee bit late in starting because we had other things to do there, but we got there, and it's now at 5:02. I'm going to bring the meeting to a close, and thank you all for taking part and your constructive way of doing so.